let's get on to some of the combos. So I just want to ask Michael a question. Talk to me about Columbus. I don't mean the Explorer, I mean the clinical trial. That was encorafenib plus binimetinib versus encorafenib alone versus vemurafenib as the control arm. So just those data will be presented in an updated form at this ASCO, and some of the data have been published recently in Lancet Oncology. So, but tell me about the data.
When we think about the BRAF mutant space, we have traditionally had two BRAF/MEK inhibitor combos, so dabrafenib and trametinib, and vemurafenib and cobimetinib. But now we have a third that's coming forward, encorafenib plus binimetinib. And the Columbus study was a phase 3 study, as you mentioned, testing that combination, encorafenib and binimetinib, versus encorafenib alone versus vemurafenib alone. So the control arm is vemurafenib alone, which would be the historical standard BRAF inhibitor. To no surprise, the BRAF and MEK inhibitor combination was better than vemurafenib alone, with better progression-free survival, better overall survival too, which was just at this ASCO meeting. So we now have solid additional data that a new BRAF and MEK inhibitor combination, encorafenib and binimetinib, here it's better than vemurafenib. I expect it'll be used. It's a great combination. It has really impressive progression-free survival and overall survival results. Now, the real question is it better or are the side effects different than the existing BRAF and MEK inhibitor combination?
Well, but Michael is, I mean, arithmetically, 33 is definitely better than 25. 25 on a good day is the best median survival you're going to see in any BRAF/MEK large adjuvant or large experience in a metastatic randomized trial.
Can I ask about that, Jeff, actually? But also we have to remember, though, that this study is done much later on. So the subsequent line therapies that these patients have on this study is very different than they would have been on the vemurafenib and cobimetinib study, as well as the dabrafenib and trametinib.
Excellent point. And it was also an international study where, some of these drugs were not available in the EU and Canada or Australia, which some of them now are, in the more current Columbus study.
So if we put the survival question, because we know it's kind of heterogeneous, difficult kind of endpoint to put aside, and we're going with cross-trial comparisons here, the progression-free survival is also very impressive. And you could say, well, maybe this was a better selected group of patients, but the vemurafenib control arm looks like vemurafenib from the COMBI-V study.
Yeah, it was 7.3 and 14.9 for the encorafenib binimetinib. 14.3 is definitely different than 11.3.
So it looks really good for encorafenib and binimetinib, in my opinion. I think the other thing that we're going to say is, although that efficacy data is very impressive, the other thing that's a real big issue is what's the side effect profile. And as we think about making a choice between dabrafenib, trametinib, encorafenib, binimetinib, and then also vemurafenib and cobimetinib, what are the side effects? What kind of patient are we treating? What's going to be important to that patient? How many pills do they need to take? These kinds of things are all going to be the intangibles that are making our decision when we do pick which BRAF/MEK combo to go with for a patient.
And the one thing that seems, in my view, to determine outcome with BRAF/MEK is disease burden and LDH. So I guess I'd want to know, in the Columbus combo arm, what was the LDH level and what were the assessment of disease burden, and is that equivalent to any other trial? Obviously, that's a back-of-the-napkin calculation, but I think that'd be very interesting.